These are the future drugs or the emerging trends in terms of newer use or reinventing our own drugs which are already present there for the use of delirium in the ICU. So acetaminophen, single center RCT of 120 patients undergoing CT surgery found that post-op scheduled IV acetaminophen combined with propofol or dexmed reduced in-hospital delirium. Valproic acid, this is a case series in which 13 of 16 critically ill patients treated with this particular drug had resolution of hyperactive delirium. However, when you see the number of patients is very, very less, and this is a case series. Gabapentin, on the other hand, RCT evaluated gabapentin in non-cardiac surgery patients found an increase in the incidence of post-operative delirium. So pre-gab evidence limited to post-hoc analysis of an RCT evaluating perioperative pre-gab with inconclusive results because of overall low incidence of delirium. Clonidine, which is an alpha blocker, alpha adrenergic agonist, a single center RCT undergoing surgical repair of aortic dissection. IV clonidine compared with placebo, this was halted because of slow enrollment. Baclofen, no evidence to support an effect on delirium. So a long list of medications there. However, no drug has been found to be effective in the treatment of delirium or prevention of it. On the other hand, you will see that non-pharmacological ones are the ones which are helping you in terms of ICU delirium. So 2018 Society of Critical Care Medicine's guidelines recommend against use of haloperidol to prevent delirium in critically ill adults due to the number of studies which we have had, which has proven that prevention is not possible with haloperidol. So no routine use of haloperidol in your patients just to prevent delirium. However, if you want to use it for the treatment of your hyperactive patients, you can use this particular medication. Atypical antipsychotics in the ICU which are used are olanzapine, risperidone, and quetiapine. Out of these, we use quetiapine sometimes in our ICU. Statins, without compelling evidence from the RCTs, guidelines do not recommend that statins be used to prevent delirium. Melatonin, as we spoke, further research is necessary, though they did improve the quality of sleep of the patients, but incidence of delirium was not altered. So Remelsion and melatonin are recommended as standard management for critically ill patients. Before this, we need more studies, and the number of patients which are recruited has to be higher. In summary, the 2018 SCCM guidelines do not recommend treatment with haloperidol. They do recommend the use of dexmed when agitation interferes with ventilator weaning. These are certain medications I have put in this slide to let you know of the doses which we use in our ICUs. If you are using haloperidol for the treatment of your ICU patients, it has to be 0.5 to 2 mg every 2 to 12 hours. And the route of administration could be oral, it could be IV, IM, subcutaneous, depending upon your patient lot, upon their own individual conditions. Certain extrapyramidal side effects are more likely at doses more than 4.5 mg per day. Also, we have to be aware of the monitoring of QT interval on our ECGs, and it remains the gold standard therapy used in our ICUs, though as I showed you, it doesn't decrease the mortality associated with delirium. On the other hand, quetiapine is 12.5 to 100 mg every 12 to 24 hours. The route is oral. Side effects could be sedation and orthostatic hypotension, which you have to take care, especially in elderly people, because if they have orthostatic hypotension, which has set in after the ICU delirium, and you have continued a low dose into their homes, unfortunately, they could be suffering a fall in their home. So be very, very careful when you use these medications. So sedating effects may be helpful in patients with insomnia. That is the reason that these patients do get better with their symptoms of delirium in these particular people. Risperidone 0.25 to 1 mg every 12 to 24 hours. Extrapyramidal adverse effects again are more likely at doses which are more than 6 mg per kg, and again orthostatic hypotension may be detrimental in your patients. It has been seen to be more effective in hypoactive delirium, given the lower risk of sedation. So other drugs we actually do not use at our center for delirium. This is just for the information. If you want to know the dosages, this slide is for remembering the doses. What would be the take-home message which we are giving today is recognition is most important. If you're unable to recognize this particular condition, if you're in your patient, if you're not suspecting it, then you may not be acting upon it, and your patients can have worse outcomes in your ICU, which is not good for either for your patient nor for your own image. Once recognized, the risk factors need to be revisited. Though we do control many number of risk factors, those which are modifiable risk factors need to be looked at, and if something is present in your ICU which can be changed, it has to be changed. For example, as I spoke about, for example, taking out the samples during the night time, which could hamper your patient's sleep, interfering with their normal sleep-wake cycle and durations of sleep, leading on to the delirium. Ensure you have adequate natural lighting in your ICU, which is very, very important for the circadian rhythm. Often a neglected feature, especially in private hospitals wherein the construction happens, or even for that matter, public hospitals, the construction is happening on the level of the engineer who doesn't know what an ICU should look like. So always include the inputs from the doctor into the making of these ICUs, wherein you have to keep windows where the natural light is naturally coming into the ICU and causing a positive effect for your patient. Always provide a home-like environment for your patient. They're all away from home, they are unwell, but you have to make it as close as possible to their home environment. Also remove their unnecessary treatment and equipment if it is there. If you think the central line has done its job, if you think the mechanical ventilator has done its job, please remove these as soon as possible and as soon as your patient has got better and out of a particular condition.